This is a myeloma patient, all rejoice. A 65-year-old with ISS stage 2 IgA lambda multiple myeloma with standard risk cytogenetics and second relapse after cilta-cel. So the patient had fludarabine LD chemo, had carfilzomib, pomalidomide, dexamethasone for one cycle as his bridging therapy, and got cilta-cel infusion. The initial cilta-cel course was complicated by day 8 fever that was deemed to be grade 2 CRS because the patient had some brief hypertension that was responsive to fluids. And day 8 is about the right time after cilta-cel, so CRS occurs day 7, day 8, so that's very on par with this CAR T product. So the patient was treated with TOC times 1 with resolution. On day 10, the patient actually had an I score that dropped to 7, no associated fever, and so he was felt to have grade 1 ICANS, and so he was treated with dexamethasone for 48 hours with complete resolution of symptoms, and the patient did well, and eventually was discharged back to his referring provider. On day 32 after CAR T, his wife calls the clinic locally, reporting that she thinks her husband is having a stroke. He woke up this morning and is unable to move the right side of his face. So this is a patient that has received a BCMA-directed CAR T product, had cytokine release, and had ICANS as part of their treatment, or part of their course, and now about 30 plus days after is developing this right-sided weakness. Maybe I'll start, maybe Nick, you can kind of take us through this, kind of your thought process, what's happening here.
Yeah, so
related, right?
being the recipient of a recent recipient of the BCMA CAR T product with, this new symptom of being unable to move the right side of the face, obviously being a CAR T center, our first thought is, oh, this is likely a cranial nerve palsy, though, stranger things have happened and people can obviously still have strokes, whether they have had CAR T therapy or not. So obviously you want to have that patient go to the ER, get a head CT, get worked up, make sure you could rule out the stroke. But in all likelihood, this is a cranial nerve palsy of cranial nerve 7, like I talked about in the presentation.
Yeah, but I think that's important, right? These patients should be evaluated and it should be emergent. I think we all struggle about this being relatively a well-known process. You still want to make sure. I mean, this is a 65-year-old person in the U.S., high risk for coronary artery disease and other vascular events. So yeah, absolutely, you want to make sure. But when the ER calls you and they don't see anything, don't. Do you want to? Are you going to tell them to give it TPA?
No, obviously, do not tell them to give TPA.
Which unfortunately we have had happen.
We have had that happen, yes. No, you want to try a course of steroids for these patients and see if they can, get some resolution. But even the steroids might not resolve the symptoms as well. So it honestly might just take time, and in some cases, that time can be up to a year. Based on our experiences here.
Yeah, no, I think that's a good point. So we all talk about this delayed neurotoxicity, but really, initially the main thing we were really worried about were the MNTs, right? The Parkinsonism type of syndrome, which is very difficult to manage and often irreversible. But the good news is, sort of with more experience and with better management of patients going into CAR T, we're seeing much less of that, but really the cranial nerve palsies are the things that we're still seeing quite a bit more. And in CARTITUDE-4, that's what was most common. And I think, one of the things, I think it's important to be aggressive with them to try and kind of, because quality of life, right? So these patients can't close their eye and get dry eye, and it's not a comfortable thing. If it's a different cranial nerve palsy where they might get diplopia, they affect the quality of life of the patient. So I agree, steroids, IVIG sometimes is recommended, but I think, like you said, the patient's either going to resolve their symptoms very quickly, or they're going to take a long time, months to even a year out. And so the take home that I have from that standpoint is not to continue the steroids forever. So eventually you'll start causing more damage than good by keeping patients on these high doses of steroids for a prolonged period of time, trying to help these symptoms If they haven't really resolved by the first, or at least improved in the first week or so, I'm already starting to kind of pull back and de-escalate. But I think that's important to remember, not to kind of keep the treatments going until complete resolution, because again, that could be months. And then the last thing you want is a patient now on 6 months of 60 milligrams of prednisone. So
I
I think it's important though, right? If they're on steroids, again, these patients now are even more immunosuppressed, so kind of infections,
Right.
those in mind as well. You mentioned the GPRC5D CAR T, and obviously we don't have a GPRC5D CAR T that's
Commercially.
commercially available, but they're in clinical trials. And what's interesting is we're thinking that perhaps some of these delayed neurotoxicities may be an off-tumor on-target effect. Because with the BCMAs, we tend to kind of see more of the cranial nerve palsies and more specifically the Parkinsonism, whereas with GPRC5D is more the oligonucleus that perhaps is involved that leads to this sort of cerebellar type of toxicity. So these might actually be off-tumor on-target effects, and we just have to kind of realize that that's happening. One of the things that's because of these potential toxicities, one of the things I think in the myeloma community that we're doing is really using CAR T now more as a consolidation therapy. So there's definitely, I think, Nick, you gave us all the potential risk factors for patients getting these delayed neurotoxicities. And we know that high tumor burden, disease that is progressing on bridging, those are pretty high risk. It sets up the patient for a much higher risk of these toxicities, again, which some can be devastating. So I personally, if I have a patient where I can't bridge well and then progressing, that I may not take that patient to CAR T. I actually may decide to go with an alternate therapy, and then reassess later on. But so that's why I think it's important to also to try, now that we're moving CAR Ts earlier in the course, right? This is indicated as early as second line. We have a lot more bridging options, and so getting those patients in good control, I think it's important that we didn't have the luxury of doing that with the initial trial.
Is there urgency? If somebody has a cranial nerve palsy and CT is negative, imaging's negative, is there urgency to start steroids quickly, or is it, is time nerve, or is it a day, 2 days? Is you know what I'm saying? Is there a
right?
There a push to get the first dose in?
Yeah, well, I think there's an urgency to just make sure it's not an acute event that's more catastrophic. But I think the urgency, and this it's actually a really good question. I think the only urgency is because there are some patients that regress very quickly, and so the idea is that if this has to do with the re-expansion of the CAR Ts, getting them on steroids may help, or at least decrease the severity of the symptoms. But I don't know the answer to that. I actually don't know. I don't know if we have any data that shows that, if you start the treatment immediately versus, 2-3 days later, if there's actually a difference in the resolution. I don't know if we have that answer. At least I'm not aware of it.